Patients with acute respiratory problems. Unit objectives are to apply the core knowledge of normal anatomy and physiology to the management of patients with acute alterations in respiratory status. Correlate the management of acute respiratory failure and acute respiratory distress syndrome with underlying pathophysiology. Describe risk factors and preventive measures for management of pulmonary embolus. Apply knowledge of modes of therapy to the management of patients with lung cancer. Describe complications, manifestations, and management of chest traumas. Apply knowledge of nursing implications and potential complications to the care of patients with chest drains. And apply knowledge of potential complications and nursing implications to the care of patients receiving mechanical ventilation. So let's look at a little bit of anatomy and physiology, a little bit of a review. Ventilation is the movement of oxygen and CO2 in and out of the alveoli. So some of our patients are going to have some issues with mechanically moving air in and out of their lungs. That is ventilation. We have diffusion, which is the exchange of gases, oxygen and CO2 at the pulmonary capillary level in the alveoli. And some patients will have some issues with exchanging gases at the alveolar level. So some of our patients may have trouble moving air in and out mechanically, but there's nothing obstructing the exchange of gases once the air gets into their lungs. Or they may have no problems getting air into the lungs, but now they're having problems exchanging gases at the alveolar level. Perfusion is when oxygenated blood is transported to the cells, tissues, and the exchange of gases, oxygen and CO2, occurring at the cellular level. So that is going to have a cardiovascular component in addition to a respiratory component. The regulation of breathing. The rate, the depth, the rhythm of ventilation is controlled in the brain by the medulla and the pons, and respiration rate is stimulated by elevated CO2. So if we are hypercapnic, then that stimulates us to breathe in and out and get more oxygen in and lower our CO2 levels, except for that patient with COPD. Their chronic condition keeps them hypoxic and having an elevated CO2 level on a continuous basis. So their stimulus to breathe is their hypoxia. And so that's why we don't want to push a whole lot of oxygen into patients with COPD until we can tell what they can tolerate. So what kinds of questions are you going to be asking with the patient who presents with respiratory complications? We're going to ask about their smoking history, their occupational history. Are they producing sputum? What color is it? How frequently is it? Has it changed from previously? What is their situation with shortness of breath, dyspnea, coughing, anorexia, weight loss, chest pain? So what respiratory type symptoms are they having and have they had? What is their family history? Because certain respiratory illnesses can be running in families and more of a predisposition. What medications are they on? What over-the-counter drugs are they taking? Because some of those can impact their respiratory situation. Allergies, medication allergies, environmental allergies. And finally, when did they have their last chest x-ray? When did they have their last PPD? Now, your patient is presenting with some respiratory issues. What is your focused respiratory assessment? We're not going to be doing a complete head to toe on these patients. We want to look at their color, their use of accessory muscles. Is there nasal flaring? Do they have equal expansion of their chest? So what they call excursion, bilateral equal excursion, which means that both lungs are inflating equally, or does one side of the chest expand with inhalation and the other side doesn't really move? What is their respiratory rate? Are they fast? Are they tachypnic? Or is it very slow? Are they bradypnic? You do need to know the normal ranges of the respiratory rate and other vital signs.